Good afternoon, and thank you so much for joining us today. I'm Crystal Yelverton, Executive Director of the Greater Los Angeles market of March of Dimes, and we are so excited to bring along our market board chair, Karen Grimley. She is the Chief Executive Nursing Officer at UCLA Health. And as I mentioned, our market board chair. Karen, please take it away for your opening remarks.
Thank you very much, Crystal. Well, I'm not sure if all of you know, but November is Prematurity Awareness Month. Premature birth and its complications are the leading cause of infant death in the United States and globally. And for us in the United States, 1 in 10 babies are born too early. And families of color are even more impacted by the preterm birth rate. The March of Dimes, It Starts With Moms series, is aimed at helping support moms and moms-to-be. We hope this webinar does just that. We'll be focusing on topics such as oral care, lactation, and baby care. The neat thing about this is going to be real how-to information and an opportunity to talk with experts or learn from experts about how you can be best prepared to enjoy your time with your baby and your family. So thank you so much for joining us today, and I hope you really enjoy this presentation. Thanks, Crystal.
Thank you, Dr. Grimley. Thanks for being with us this afternoon. And so for you all, we will have time for a Q&A at the end and invite you to put any questions that you may have in the Q&A box at the bottom of your screen. And you can do that throughout the presentation. We'll make sure that those questions get to our panelists. And I invite each of you to share who you are, what organization you might represent in our chat box. We want to have an engaging conversation this afternoon and invite you all to share where you might be joining us from in that chat box. Now, I am thrilled to welcome and introduce our esteemed panel today. First, we have Dr. Ashley Abrams. She is the owner of 2 dental practices located in Temecula, California, Pacific Dental Group and Orthodontics, and Temecula Martin Dentistry. Dr. Abrams' model of care emphasizes the importance of understanding the oral systemic link, also known as the mouth-body connection, in order to improve the overall health of her patients. Thank you so much, Dr. Abrams, for joining us from Temecula this afternoon.
Thank you. I'm very excited to be invited to this.
Excellent. Next, we have Corky Harvey. Corky is the co-founder of the Pump Station and Nursery. She is a registered nurse with a master's degree in maternal newborn nursing, as well as an international board certified lactation consultant. We're really excited to have Corky participate in today's discussion and welcome you as a panelist, Corky.
Thank you so much. Glad to be here.
We're glad to have you. And next we have Dr. Sarah Green. Dr. Green is a pediatrician at Private Medical Los Angeles, approaching medicine with a holistic and preventative care focus that also adheres to the most up-to-date evidence-based practices. Thank you so much, Dr. Green, for also being a part of today's panel.
Thank you for having me.
So we are going to jump right in with our questions, starting with Dr. Abrams. Dr. Abrams, first, let me start by congratulating you. I heard that you recently welcomed a new family member. We're really excited to share in that celebration with you and your family.
Thank you. Yeah, I just had a baby boy 10 weeks ago, and in 2021, I had a baby girl. So they're a year and 2 weeks apart.
Wow.
I love it. And I love that you're here with us with those 2 littles back at home. Thanks so much for sharing that with our group and our audience today. Well, let's throw you our first question.
Okay.
Can you explain the relationship with oral health and pregnancy outcomes?
Yeah, so a lot of people don't realize what an impact pregnancy has on the whole body, right? Especially the mouth. I mean, the mouth is often separated, dentistry is separated from the rest of medicine, but I mean, the mouth is our opening to our body. Everything goes into our mouth, eventually gets into our bloodstream and can affect other organs in our body, and of course, a growing fetus. So I think this is something that until I went through my own 2 pregnancies, I didn't realize the effect and the impact on it. So it's definitely opened my eyes. There's a lot, like I said, that you go through. A lot of women suffer morning sickness, acid reflux, these conditions that bring a lot of acid to our mouth. Well, cavity causing bacteria, they love acid. So that's going to put your teeth at higher risk for developing cavities. Periodontal disease, gingivitis, the blood flow in our mouth changes when we're pregnant. It puts us at higher risk for inflammation. If we have these bacteria that cause periodontal disease, or we already have periodontal disease, it does cause risk factors for the fetus as well. And so they've actually found that the bacteria involved in periodontal disease, the inflammatory factors, can cause preterm labor and can have an effect on low birth weights as well. So it's really, really important that, you're taking care of your mouth in order to take care of your body and take care of your baby as well.
Wow, Dr. Abrams, that's great information. And, thanks for sharing how even as a dental professional, you became even more acutely aware once you went through your own pregnancies of that connectivity and sharing what that experience was for yourself. Thank you for those examples.
Yeah.
Next, we're going to bring Dr. Green up for a question. Dr. Green, I'd like to ask you first, really highlighting that most parents probably don't think about the pediatrician until after the baby is born. It's like, oh, what's next? But really, from a pediatrician's point of view, when is the best time to select and meet with your pediatrician?
Yeah, well, it's a great question. I used to work in the delivery room. And so the first thing they asked these new moms is, who's your pediatrician? And often it was like, what? What do you guys have to do? But yeah, so it is something that I think knowing before you go to the hospital is ideal for sure. But even beyond that, I mean, some of the things that Dr. Abrams was bringing up too, there's all these things that happen during the pregnancy with the mom's health that can then go on to affect the baby's health or when the baby's born even. And the OBs are usually really good about this. But ultimately, I think for a lot of parents, hearing from the person who's actually going to be caring for the baby or who's cared for premature babies or who's taking care of kids with flu or, different things that we actually have preventative measures for during pregnancy. And so ideally for me, I meet with the parents in the middle of the pregnancy, 3rd trimester, maybe. But I talk to parents right now about, have you had your flu shot? Have you had your Tdap? Who are the caregivers going to be? Have you had your COVID vaccine? Getting vaccinated in the 3rd trimester is protective for the baby. And then beyond the direct medical interventions that we have, I also think that there's a lot of social support things that I like to check on before the baby's here. So I always would be a little bummed out when I would be meeting a family for the first time in the hospital or after discharge from the hospital and realize, oh, shoot, I wish I would have known about this dynamic with the family or that you didn't have this support in place. Or, I would have made suggestions that now it's too hard to implement once baby's here. So.
Oh, wow. Those are some really great points. And thank you, Dr. Green, for really sharing the different levels and layers to that. When you think about that social support and what does the family home life, what does that village, if you will, look like surrounding mom and baby when they are discharged? There's so much more to it. I love, having that milestone midway through pregnancy or the beginning of the 3rd trimester, those planners or organizers, they can put that on their list, if you will, as they're thinking about their family planning. Yeah. Thank you so much for those. And next, I really want to bring Corky into the conversation. Corky, as a lactation consultant, tell us a little bit, about Are you also looking for signs of postpartum depression? How are you checking in on mom's well-being when you're becoming part of that care team and coming into home or coming into recovery after delivery? What are some of the other things that you're looking at with mom?
It's a great question, and I think lactation consultants are really well poised and positioned to pick up on the postpartum issues that happen with mothers. We are sort of, I see ourselves sort of in a slot between pediatricians and obstetricians, and oftentimes mothers will, they might not have the same time or ask the same questions that would show that these women are already struggling. And interestingly, the first week postpartum is a perfect time to pick up major symptoms of postpartum depression or women at risk. And back to Dr. Abrams, what she said about inflammation in the mouth, pregnancy inflammation is at risk for causing premature birth, but also wonderful evidence-based information shows that inflammation plays a huge part in maternal depression. And so reducing that during pregnancy in the first place, and also addressing that in the postpartum period, the major stressors. And we do pick up, and many of us will even use a tool to evaluate. And there's now 3 questions out of a 10-question from the usual used Edinburgh postpartum depression scale that you can ask 3 questions, and oftentimes you don't have to ask them, they come up. So are you experiencing additional stress? Like, are you visiting your pediatrician or calling her all the time for things that normally women or families wouldn't call for? Are you blaming yourself unnecessarily? Are you not sleeping? Are you not eating? Or have you felt scared or panicky? So we can pick those things up during these visits with these postpartum families. And so, yes, that's really part of the scope of our practice. Diagnosis not, but impression and involvement in suggesting treatment and interventions for postpartum women, crazy important. And I would add to what Dr. Green was saying about preparation, knowing where lactation help is hugely important, and being involved in it before you even give birth. Take a class with a partner, a mother, whoever's your support system. Know where your lactation people are other than just the hospital, so you have good follow through. Because what's also true is that breastfeeding, and this is something that is mythical among women, breastfeeding actually lessens the risk of postpartum depression. Women who are breastfeeding actually get more sleep and down-regulate stress because of this wonderful cascade of hormones that are going on in our bodies. So it's important for us to propagate that. And when I teach my breastfeeding classes, that's one of the things that I talk about is reducing the risk of postpartum depression through breastfeeding. Add to that, which you didn't ask, but babies whose mothers are depressed are at risk for major mental health issues. But babies who are breastfed, by the way, through the mother's depression, it's enhanced by the fact that she has to hold and touch. And even Brooke Shields identified that in her book, where she felt that if she'd lost breastfeeding, she would not have made it through. And so the breastfeeding connection can be a huge benefit to lowering the risks of depression.
Wow, Corky, those were some great tips. And I love that footnote, where you made the connectivity to that touch and feel with the connectivity during breastfeeding and the impact on mom and baby. Thank you so much for those pieces of information. Dr. Abrams, bringing you back in, tell us, what should a pregnant person look for? Is there anything in particular that would be one cause of concern?
Yeah, so I mean, I think to have swelling in the gums, have bleeding, inflammation, soreness in the gums, those are definitely things you want to look out for. If you're having any sensitivity in your teeth, any pain, anything like that, it is safe to get dental treatment done during pregnancy. And I think that's something us as a dental community, we need to get better at, because most OBs are more comfortable referring their patients to dentists than are treating them as dentists. And like I said, even myself, until I went through pregnancy and I had to have a root canal during my pregnancy, Yeah, so it's one of those things that I think as a dental whole, we need to be more comfortable. I think patients need to be more aware. A lot of times I have patients that come in and they say, well, I didn't go while I was pregnant. I couldn't go because I was pregnant. Oh, we can't take x-rays because I'm pregnant. I can't. This is a time when we need to be even more persistent about getting those checkups, getting those cleanings. Some of my pregnant patients, I'm seeing them every 3 months. So that way we can control their periodontal disease, control the inflammation in there. So yeah, definitely. If you notice anything out of the ordinary, get to a dentist right away. We're trained to be able to treat pregnant patients. It's totally safe. If for some reason we feel the need, we'll reach out to the OB and if there's any additional clearances we need to get.
Wow, that's great information, and highlighting that it's safe to go through those dental procedures. And my takeaway, Dr. Abrams, there is really, it's probably safer to go through those routine dental procedures and make sure we're taking care of things on the front end than to wait through the pregnancy and the potentiality of it festering into something greater.
Absolutely. I mean, having infection in your mouth, having disease in your mouth, that's risk to the baby. So want to make sure we minimize that risk, the baby as healthy as possible. And even, when I'm meeting young women and, they're talking about, oh yeah, we want to start a family soon. I'm encouraging them, hey, now's the time to get your mouth healthy. Now's the time to be healthy, because a lot of times we see things blow up during pregnancy. And, a very common example is wisdom teeth, right? A lot of people, it's best, easiest to just get it done under sedation. Well, when you're pregnant, we can't sedate you. So that's, when we hear a little bit more of those horror stories about, oh, I had to get my wisdom teeth taken out and I was wide awake and I felt everything. So we try to prevent those situations, prevent, the risk to the baby.
Absolutely. Preventative care when we can is the best care. Thank you, Dr. Abrams. Dr. Green, tell us, pediatricians are probably the first people to see mom after discharge from the hospital. Because of that, you also are checking in on mom. What does that process look like? And what are you looking for as a pediatrician when you're seeing mom on that first baby visit?
Yeah, well, and to piggyback a little bit on what Corky was saying too, we have a team in place. We're working with lactation, we're working with the OB team. And ideally too, I've seen the baby in the hospital. So my first visit, hopefully I'm not meeting the family, but sometimes families are at hospitals where we aren't able to go see the babies. And, but in that first visit, we're doing a lot of what Corky was saying too, checking in with mom. Are you sleeping? Are you eating? What's your support system? Feeling a lot of the dynamic in the room, who's there, who's not there, who's at home. How is that going? Obviously we do a checkup with the baby and we have a whole list of things we're looking for, jaundice and weight. But a lot of that initial visit is also checking in with the family. And, the OBs don't see, like Corky was saying, they often have a 6-week follow-up visit, right? And those moms have just gone through, a major event, and there's all these other risk factors and issues, things that can pop up during that time. We do postpartum screening as well. As Corky mentioned, I love, if I hear from a lactation consultant, obviously I don't love to hear that the moms are struggling, but when I get more information than just breastfeeding's established, baby's weight's improved, jaundice is improved, but when I get things like, hey, mom mentioned that she's waking up having panic attacks in the middle of the night, or mom, I'm worried about this other dynamic that's happening in the house. That's just priceless to be able to intervene early. And then also another thing I wanted to mention too, to Corky's point, is that with the lactation support, like Corky mentioned, it's very different depending on where you are and what hospital you're going to deliver at. So I think a lot of moms do tour the hospital, but they're asking questions like, where's the parking? Where do I check in? But ask the questions, what's the lactation support here? What does everyone get to see a lactation consultant? Because I think people are surprised to find out, oh no, you have to have these 3 risk factors. Otherwise you don't automatically get lactation in the hospital. And so calling your insurance company and saying, what are my benefits? Who is the lactation support? Finding out how much it costs, what can you budget for? And just having that in place, because I do think that sometimes when I see parents on that first visit, it's overwhelming and they're not sleeping. And those kinds of details can be what makes or breaks them from getting to the support they need. But if we have that in place already, it's so much easier. So
May I add to that for just
Absolutely.
a lactation? I mean, I think there's a lot, I see it all the time when women did not prepare. They'll say things like, well, I got ready for birth, but I didn't realize that breastfeeding was going to be harder than that. They don't really know where their helpers are, and they think the hospital is going to handle it. And it's, I mean, on weekends, sometimes where there's a hospital that has some support, there's nobody there. And the nurses have some training at times in some hospitals, but it's not consistent. And so knowing where your help is outside the hospital, and interestingly, insurance is paying in many cases for home visits from lactation consultants. There's a lactation network, it's called, and many of our consultants are on that. And you can see a consultant for 6 times sometimes. Now, and everybody's insurance doesn't do that, but so much compassion among lactation consultants that they'll help moms usually, even if they can't pay in some situations. So I just don't think people think beyond that hospital. And also, if your class is a half an hour, yeah, that's going to be some help, but my classes are 3. And we want the partners there and all the help that we can get in so you understand the process. You would be amazed at how many women do not understand the basic premise of how to get a milk supply, which is milk out, milk in. So it's just incredible how much lack of information is there. So taking advantage of it. Our support group is free. So you can get to, and many are, so the help is there. Just access it or find it before you're in trouble.
And identifying that partner, you mentioned bringing the partners to the group, whether that's a friend, whether that's spouse, a parent, but having that person identified ahead of time. There's really good data that a supportive spouse or partner for the breastfeeding journey increases rates and success with breastfeeding.
So significantly. Yeah. So especially in that if a woman is so kind of spaced out and stressed and she just can't think for herself, she might run an entire company, but that particular time in her life, she needs an advocate. She needs somebody to stand for her and say, yeah, thanks for like somebody who said to me, you don't ever rock your baby, and have my partner say, no, wait a minute, that's not our choice. Just have somebody there to really help you through all those struggles by being your advocate.
Oh gosh, what powerful advice. And, having you both just sharing that dialogue, Dr. Green, your points, and Corky, really you coming in and underlining and adding on to that, I think really is a demonstration of why we wanted to have today's webinar. It starts with mom, healthy moms, strong babies, with the 3 of you, Dr. Abrams as a dental professional included, because it's the holistic care of mom and baby that makes a difference. It's the collaboration of all of those members within that care team that I think makes such a difference. And that actually transitions us into my next question to you, Corky. We've talked a little bit about your role as a lactation consultant. Can you explain briefly what are some of the things that you all do and focus on? What are some of the intricacies of a lactation consultant and your role as it pertains to mom?
Well, our whole thing is about moms and babies. That's where we sit. I've always said breasts are my life, so, but there are so many different things that can happen postpartum with breastfeeding women other than mental health issues, but it's all tied together. So they come to us for baby inability to latch, low milk supply, sore nipples, just a big wide range. And so we do a whole kind of health history with them to see what could be contributing to their issues. And some of them are simple fixes. Just a deeper latch can be just a 20-minute session where we teach them how, and it's like miracle work. It's fun for us and challenging. And today on my support group, like last week, I had 18 moms, I think, and every single one had kind of a different issue. They also want to know a lot about, they have questions. How do I put my pump together? When do I pump? How do I get my milk supply up or down? Why does my baby have green stools? it's just crazy fun. So there's a huge section. And again, I say, I think we fit in this position between the OB and the pediatrician, and we can feed a lot of information to the pediatricians who may not have as much time as we do with that mom. Some of the home visit sessions are 1.5 to 2 hours long. And then some are just quick times. So we do a great deal of that work. So we do concentrate on baby's weight, et cetera, because we know how to we teach moms what to look for in how to tell a baby's getting enough food so that they're well educated in that. We encourage them. I probably say, Dr. Green, 40 times in my breastfeeding and baby care classes, this is their sign. I tell them, because we're teaching on Zoom, this is call your pediatrician. That's your sign. And we work together with that. So we've got a baby well underweight. When we see them, we're going to be on the phone to the pediatrician and say, we're sending them over for a further evaluation. So we fill that role as well. And then it's very easy for us to pick up the postpartum depression and struggling issues, or even health issues. I mean, I sent a mother last week back to her OB to have a panel of blood work to look at her thyroid levels and her prolactin levels and things like that. So there's a real role there as even a go-between. And I think they'll talk to us. Sometimes they don't have the opportunity with their OB, or maybe they don't feel that's where they sit, and maybe they don't see them in that role, but they will kind of break down and talk to their lactation consultant in many cases. So we're hopefully empathetic listeners as well.
That's really great. Thank you so much, Corky, for that information. I'd like to shift back to Dr. Abrams now, if I might. Dr. Abrams, you really pointed out some things that mom could do to ensure her oral health doesn't affect her pregnancy. Now thinking beyond pregnancy, would you share what should a family be concerned about if they have a preterm baby? What are some things they should consider after delivering a preterm baby?
Yeah, so some of the things you'll notice is preterm babies, their teeth can be delayed, their eruption. So instead of coming out, the normal time range, they might get their baby teeth later. Typically, when we see them get their baby teeth later, a lot of times that affects the adult teeth, so they'll get the adult teeth later as well. They can get enamel hypoplasia, so basically weaker enamel, that can cause their baby teeth to be at higher risk for cavities. If they have to be intubated, that can affect the formation of the palate, which can lead to like crowding issues. So, orthodontics, appliances, that might be something that they have to consider. And then discoloration. I read that high bilirubin levels can cause discoloration of the teeth. So it looks like from my research, most of the conditions affect the primary teeth, the baby teeth, which is pretty good. So thankfully we get that second, but just making sure that we're establishing good oral hygiene from the beginning.
Great. Now that's helpful, and some signs of things to be aware of, and things to know to sound the alarm if you might need to. When you're thinking about your child's first dental appointment, when should parents plan to schedule that, and should it differ if you had a preterm baby, and how should they prepare?
Typically, for babies, we want to see them either by their first tooth erupted or by their first year. So whatever comes first. So even if they don't have any teeth by their first birthday, we still want to see them. I've actually heard from patients, or read online or seen people, they call the dentist says, oh no, we don't need to see them until they're 3, 4, 5, 6, until they have all that. You definitely do not want to wait that long. So initially when babies are first coming in, we're taking a look in their mouth, making sure everything looks normal. And it's a lot more just getting the kids comfortable with the experience. You want to make it very positive when you're taking your kid to the dentist. You don't want to threaten them. Hey, if you don't brush your teeth, they're going to have to get shots. They're going to have to drill in your mouth. We try to keep a very positive impression on them, so that when they enjoy coming to the dentist, they know they're going to be taken care of. A lot of it's education to the parents on, how to brush, how to floss. Diet is a huge part of preventing tooth decay. So educating the parents on, what snacks are healthy, what is unhealthy, what habits are good. So it's basically instilling those good habits, getting them familiar with the office, and then identifying any issues at an earlier age. So that way we can be proactive if we have to, seek treatment. So if you ever call a dentist and they know, find another dentist. That's why we have pediatric dentists. So a lot of general dentists aren't comfortable seeing the little ones, but pediatric dentists, that's what they're trained for. So find a dentist who will see and take care of your child from a young, early age. Don't wait until they have all their teeth in, because sometimes it's too late.
Such great advice, Dr. Abrams. And I appreciate your call out about the pediatric dentist. In some cases, maybe your family dentist isn't right to start baby with if they're not comfortable seeing your 1-year-old, or maybe even your 9-month-old, if that's the site of the first tooth. So thank you for that call out and those tips there.
Of course.
And before we shift to our next question, I just want to say thanks again to all of you for joining us this afternoon. I've seen a few more folks hop on. We invite you to drop your name and your organization in the chat box. We'd love to know what organizations or what groups might be with us for these It Starts With Mom conversations. And we also invite you to go ahead and begin uploading your questions for our panelists in our Q&A box. We will jump to our audience questions in just a few minutes. And with that, I'd like to jump to our next question for Dr. Green. Dr. Green, I'd love to hear your thoughts when baby does arrive early, but has been discharged from the NICU. As a pediatrician, what are you looking for, and how does this care change? What does that look like at the onset of care for a NICU discharged baby?
Yeah, great question. Well, first, NICU babies are, if you know one NICU baby, you know one NICU baby, right? None of them are the same. And if you have a 25-weeker, you might have a 39-weeker who spent a day or two in the NICU or longer. So they all have very different needs post-discharge. And some actually maybe don't even have anything different than a normal newborn baby. By the time they go home, they're sort of the same as a baby who's going home from the nursery. But in general, I like to be in touch with the NICU team and have at least a phone call. We'd always usually get a discharge summary, but some contact to know what's, the NICU course was like. I sometimes will even be involved during the NICU stay. That's ideal if the pediatrician can, especially close to discharge, to get to know the baby, know their breathing patterns, know their feeding habits, know how they spit up, know what those kinds of things, because those things will happen again when they go home. And then it's usually busy for the babies who have a more substantial NICU stay, and the more premature babies, there is a lot to keep track of after discharge. And so for parents, having the paperwork, having all of that, and really handing that over to the pediatrician too, and involving them as much as they can in that follow-up, the specialist visits, keeping them in the loop, making sure all the visit notes, specialist notes go back to the pediatrician too, to keep them involved as much as possible, I think can be really helpful. So if anything does come up, usually we're the first call. And then the other thing I love about the NICU, we call them NICU grads, but there's a slow process then, as those babies do have some special needs, especially after that NICU discharge, especially the more premature babies. But as over that year, 2 years, those NICU issues just start to slowly fade away, and they usually drop off. They pass their eye exam, they get cleared by cardiology, all those things sort of, for a lot of the babies at least. And we get to sort of transition them into the regular old pediatric care and get to help those parents sort of, have the regular colds. And this is just a cold, this has nothing to do with NICU, or this is just a sick kid with a cold and a fever. So I'll always love that process as well. And even some of our babies who really continue on with special needs, and they still have the regular old behavioral stuff, and it looks different in every kid, but, getting to know those families and help them transition into that, just sort of, as I say, regular old pediatric stuff is a fun journey too.
That's great, Dr. Green. And watching you light up as you talk about those celebratory milestones for our NICU grads just warms my heart too, because you recognize that that is a transition for the family, you know, transitioning out of the NICU to, you know, wellness. And we're having wellness visits. Oh, this is the common cold. And even if you've not had a NICU baby, coming off of this COVID wave, I think this
Yes,
season,
we're all
we're
transitioning.
all appreciating, oh, this is just a common
Yeah,
cold.
yeah.
And that certainly isn't to take lightly of when it's not, but it's the recognition of when it is. And that is something that is a win for those NICU families. So thank you.
I always joke, and Corky probably knows these families too, but I always think it's a milestone when I ask how the baby's feeding and they don't give me the volume in milliliters.
Uh-huh.
You know, we've made a big mile. They always say, I don't know, we're just feeding, you know, it's like he feeds when
We're
he's
eating
hungry.
good.
You know, yeah. It's like
I
great.
love it.
Yeah.
I love that. Well, let's bring Corky in as we're thinking about these milestones and really considering those premature babies and your role as a lactation consultant. Tell us what happens with the breastfeeding journey if baby is premature. What are some of the tips and suggestions that you have from your point of view?
Again, it's going to depend on the prematurity level too. Some babies don't get to have time at their mother's breast for weeks and months. So the first step, I think, is to establish a milk supply, which is really important for these moms who feels connected to the baby to be able to provide milk. And there's been a lot of myth around this, like if your baby's only weighs 3 pounds, they don't need as much milk as an 8-pounder, but we like to help moms get their milk in as if they had an 8-pounder, because it's, or a 7-pounder, whatever, it's our full-term baby. It's hard to drag it up later as compared to getting it in early. And so, and also that some of those babies, and I'm sure Dr. Green could address this more, they will even bathe the inside of the baby's mouth with the early milk, the colostrum and the milk, so the baby begins to build their microbiome based on breast milk rather than other things. And the importance of having these babies, when they're able, receive breast milk, so that if the mother isn't even making breast milk, many of the hospitals use donor milk because there's a high relativity to have major health issues if those babies are not receiving breast milk. So encouraging those mothers, teaching them how to hand express. There's actually evidence-based information that hand expression in the first 8 to 12 hours is more effective than the best pump in the world as they transition, and value to the milk. So I can remember times, because I've been in this field for a long time, when nurses would say, and I was the first lactation consultant on the west side of LA in a hospital, and I was at Santa Monica, UCLA, where nurses would even say things to patients like, it's just colostrum, you know, it's like, it doesn't matter. And I believe we've transitioned in most areas out of that. There's even little tiny tubes you can collect colostrum in prenatally for a mother who's diabetic, for instance, who that can benefit her baby post-birth. So there's more value to the breast milk. And we like to promote that a great deal. So I would, if a mother's knowing she's going to deliver and possibly prematurely, or twin mother or somebody that's in that risk factor for early birth, I would like her to explore whether there's lactation availability within the NICU. So one of my coworkers and a friend for years, a fellow lactation consultant, works at the NICU at UCLA. And I think Westwood also has that in place. She's not there full time, but boy, is she busy teaching even the nursing staff the value. And so there's been a huge change and shift toward support of breastfeeding within the NICUs. And then the other issue comes when these babies are transitioning off feeding tubes, and they usually go on to bottles, even though there's really good evidence that breastfeeding is less stressful to a baby if the mother has that good milk supply. So there's a lot of work right there in that transitioning off. And as you've all heard, some babies will not transition well because they're so used to the bottle that they don't know how to transfer well at the breast. So that's where we come in on the home after they're home, is working with them on getting back to breastfeeding. We can actually weigh a baby pre and post their feeding, so we can tell what that baby's transferring. And sometimes they really need support of bottled breast milk after the feeding, and that those moms are working hard because they're breastfeeding, they're pumping, and they're feeding by bottle. So that's called triple feeding, and it is a challenge. I'll have some moms on my support group today that are doing that as they transition. So they need tons of support through that process.
Yeah, I just want to echo that as a pediatrician who spent a lot of time working in a NICU. This was something I would often bring up on rounds was, has the baby gone to breast? And it was often something that was forgotten about, understandably, because we're thinking about oxygen levels and medications and infections. But we forget sometimes to put the baby to the breast because we have the milk, the mom's pumping, and we can measure it. And it's also easier. Medical professionals, we like to know exactly how much you're getting, how much you weigh. But doing that before the baby goes home, especially if there's lactation support in the hospital, because then we can monitor the oxygen levels on while the baby's at the breast. If the baby gets choked, mom can learn all those things and strategies in the hospital. So just encouraging people to really ask that question. And maybe the answer is not today or baby's not ready, but can we try that today, and just to keep asking. And then the other thing I wanted to mention is that Corky brought up donor breast milk, which the NICUs are excellent about now. It's really evidence-based. They use it for the premature babies. It's also available outpatient. Often California has, I believe it's mothersmilk.org, and some human milk banks that premature babies especially will qualify for. And sometimes insurance will even cover it. So if you're a mom who's having trouble with supply, and your baby's been getting donor breast milk and now you're ready to go home, it's something to look into, and you can get it sent to your house too.
Adding to that, Dr. Green, the putting these babies to breast, even if it's not very effective, as far as transfer of milk, is hugely important to that mother. It lifts her milk supply. She'll go out and pump more than she ever has just because her baby went to the breast, and beginning that important bonding process. I mean, there's years worth of evidence-based information on that topic. And she's so right. They get busy with the number of meals. And by the way, mothers are into that. I'm not a big fan of all the apps. I think they have an important place, but oh my God, when they tell me I made 200 meals today, and I go, how
Yeah.
often? It's I'd rather see them put pen to paper for those first few weeks and just look at a few things, and then to let go. And that's a hard transition piece for the NICU moms, to let go of all that calculation, because there's a tremendous fear factor. And so we support them through that process, when to let go and stop all of that extra work, if you will, to monitor all that stuff unnecessarily. Yeah, we want to know, even on full-term healthy babies, how much stool and urine they're making in that first week of life, and when they weight, and yeah, we want to know all that, but not 3 months. I have mothers 3 months later still tracking every poop, and it's like, yeah, we don't care. So we want to let go and just be more intuitive once we get past a certain place.
Mm-hmm.
What great knowledge again. While I've got both of you together, Corky and Dr. Green, this question is actually for either of you or both of you, if you both have something to add in the essence of thinking about breast and putting mom to breast. One question that many of us are curious about for a breastfeeding mom, or a mom intending to breastfeed when she can get to that stage, when should they introduce the pacifier, if they should introduce a pacifier?
Well, do you want me to, that involves Dr. Abrams pretty much, I say.
Yeah, I was going to say, this is a threefold, or when they stop the pacifiers, maybe Dr. Abrams.
That question too, Dr. Green. Sorry about that, Dr. Abrams, Dr. Green and Corky.
Yeah.
Well, I guess I can lead this discussion because it's not simple. I remember one time walking into the nursery and asking for a pacifier, and the nurse addressed me derogatorily, saying, I thought you were a lactation consultant. Well, there comes a time when balance is important. And I think as lactation consultants, I think we can be too harsh with too many rules that don't work well for all parents. So our advice is actually to try not to introduce it in the first few days to weeks, because sucking at the breast brings the milk supply. That said, there are times when if the partner can hold the baby while mom gets a shower, and we know that sucking is calmative to babies, why would we have a rule like that? Maybe the baby sucks his finger for a few minutes, or a little passy. And we do talk about types of passies, and I think Dr. Abrams can address that too, but we've been in connection with lots of pediatric dental conversations and even conferences, and they're not a big fan of orthodontic type pacifiers that put pressure up on the palate. But we like a pacifier with a little bit more of an areola, and also perhaps made out of one type of plastic rather than two, where there's more opportunity for a loosening or bacterial growth. And so we say minimalist, but needed, because we want to give parents tools on the tool belt. So I teach Baby Care 101, how to calm babies too. And there's a huge relativity between being able to calm your baby and feeling good as a parent, and also lessening the risk of abuse to babies. So we need to be very careful how we talk about these kind of things. So we're not going to feel negative, but or say to somebody, no, you can't use. And I think that's pretty often done in the lactation community, when some babies need different things. So, but I also see parents just stick it in a baby's mouth when they're smiling at them, and they don't need that. And so being more attuned to that. So I'm going to be quiet now, and because I'm sure there's other thoughts here.
No, I agree completely. And I always try to, think what's the evidence first. And there is some evidence that there's decreased risk of SIDS with babies who have pacifiers. Certainly breastfeeding decreases risk of SIDS. It's not strong enough that I'm, putting pacifiers in every baby in the nursery when I see them. And I agree with Corky that getting the breastfeeding established, it's also different if this is third baby and mom's got, 2 kids. She's done this before. My sister jokes with her third, she had to sneak and steal pacifiers off the cart because they wouldn't give her one because she was a breastfeeding mom in the hospital. And, but, so we just, like Corky said, we get so hard and fast with our rules sometimes. And Corky, I'm sure, and, Dr. Abrams probably has experienced this with her own kids, but there's some babies too, these just big, effective eaters who just want to suck all the time, and these moms have raw nipples and they can't get a break, and the baby's and this baby's growing and gaining weight, and at that point then that's a great baby to have a pacifier for, because they're just not calmed unless they have something to suck on. And there's other babies that probably don't need it, and they're calmed with swaddle or other techniques. And then I agree with the, minimalist. And as the kids get older, that's something I'm talking to the families about all the time. And as speech is starting, 9-month-old, 6-month-old, they're starting speech, right? They're babbling, they're mimicking, they're doing some call and response, reciprocal interaction. And if they always have a pacifier in their mouth, that is going to interfere with that. And so using it for sleep, using it for travel, using it, when you really need a break or you have to go to your cousin's wedding or, whatever it is, having it. And then also as they get older, it is a special thing then. And when it comes out, it is very soothing. It's something, if it's there all the time and they're running around and, talking through it and eating through it. And, then there can be increased risk of ear infections and other things too, if they just always have that in their mouth. So using it effectively, if that's what you choose. And I have some families who don't want it because they don't want to have to take it away, and then that's fine too. I don't feel so.
But I find, Dr. Green, so I find sometimes I work with families on the idea that we don't try to prevent, we stay in the moment of where they are, rather
Yes. Yeah.
having to take away a pacifier just because I don't want to do that. So I let them have it when they need it. And sucking is a very strong need of some babies, like you said. The other thing I would bring up, and Dr. Abrams would want to talk about this, I had a thumb sucker. Now that babies are sleeping on their back, we don't see as much thumb sucking because that mouth isn't right there. But man, oh man, she sucked for 12 years and she had orthodontia, and one of the kids that did have orthodontia too. But there is a pacifier or something you can take away more readily. Yeah, you might have a couple of tough nights so I've had people cut off the end and say, oh, so Binky's broken, or something more psychologically friendly where you say it's just for night time and we'll put it on the pillow, or we're going to mail it to our friend who's having a baby, or whatever people can do. But you can, and you do have to deal with things through babies' lives, but not doing what they need at the moment of their need doesn't make sense to me. Deal with it down the road if you have to.
Yeah. No, I agree. And I think parents fear that more than the actual event of taking it away is not a thing. And, the other thing I get is, we're going to lose it, or it's going to fall out of the crib, or we're never going to have them when we need one. There's all these fear, but I agree. I just say, like, in the moment, if it's working, you can cross that bridge later. And maybe when they're 6 months old, they won't want it anymore. They won't have that strong need to suck, or you never know. So just, yeah.
So as a dentist, like, I've always been very anti-pacifier, right? I mean, once I started having babies and started learning more, the decreased risk for SIDS and everything, but just as a parent myself, that's one of the things I'm like, I don't want to have to deal with getting rid of it. Well, my daughter, right around her first birthday, I think around the same time the baby came, she started sucking on her finger. So she's been sucking on her finger now for the last 3 months. And I'm like, okay, right now, developmentally, like she's too young to try to break this habit, but I'm really not looking forward to breaking it.
Yeah,
She didn't give you a choice. She did it on her own.
right,
Yeah.
exactly.
Yeah, I think that's just my karma as a dentist is, I gotta deal with these things. She also, she doesn't like having her teeth brushed. So that's always a fight too. I literally have to sit on her, hold her down, brush her teeth. So that's what I get.
Right.
Love these life lessons, but also these life curveballs that will be in our focus area. Dr. Abrams, thank you so much for sharing that. As we've said, we welcome questions from our audience this afternoon to add to this very robust conversation. And we have received a few questions, so I want to jump right over to those. The first question actually is going to be for you, Dr. Abrams. So I am going to spotlight you, if I might. And that question, Dr. Abrams, I'm a dentist and see a lot of pregnant patients with acute problems, often severe periodontal disease, but sometimes cases of abscesses. Any suggestions on how to reach those patients and encourage regular dental visits when they aren't already coming in?
Yeah, so that's tough because if they don't know and they're not coming in, right? How do you let them know? I mean, I think things like this help spread that message. I think that's something, that in the OB community, there can be more awareness of, and just educating, just asking the simple question, when is the last time you've seen your dentist? Hey, it's really important to get checked up. I know me, like I'm very involved on Facebook, social media. So I try to put that message out there, like in my community, like Facebook pages. Hey, it's okay to see a dentist while you're pregnant. Come see me, I'll take care of you. And I think too, even just myself, this is something I can be more proactive about, is reaching out to the OBs in the community and letting them know, hey, if you don't have a dentist that's comfortable treating or seeing your patients, send them our way, send them to me, I'll take care of them. And just really emphasizing that importance of the oral health care during pregnancy.
Dr. Abrams, that's great feedback. Thank you for that. Our next audience question is for Corky. Corky, when should a family introduce pacifiers, which we just touched on, but from your point of view, really thinking about that really robust pacifier discussion that we just had, how do you suggest skipping sippy cups, or do you suggest skipping sippy cups, to your point about meeting a child where they are and their needs at the moment completely, as well as straw cups versus regular, cups without any of those accoutrements?
I think Dr. Abrams would be involved in that too. So there's a functional pediatric dentist that we work with on the west side here. And she doesn't care for sippy cups. She prefers straw cups. I don't know if Dr. Abrams as well. And so introducing those, babies can learn to suck on those when they're 4, 5, 6 months old and start working with them. There's a lot of cups that have a little weighted ball in the bottom so they can set them up. They don't have to tip them. And so we talk to her now and then about a product, so we make sure that we're carrying the right products. She does a lot of work with, and I bet Dr. Abrams does too, about even having those little toothbrushes that fit over your finger and massaging. And she teaches us to have the moms sing a song while they're brushing their little teeth, even just gum rubbing, so they're getting used to that. But back to the pacifier, we say try not to introduce it much before the 2nd week so the mouth is well established, and then see what your baby needs. But because, as we discussed, they're different needs, and some babies are the suckinest things on the planet. And the mother who said she's never going to use a pacifier because she didn't want to is the one who gets that baby, by the way. And it's a real conflict for her. And so we try to say, don't make all those decisions until you know who the heck you have. I have 3 kids, and they couldn't have been more different. My daughter has 2 sons, and they couldn't have been more different. So you have to see who you get. I thought I was a pretty sharp mother with my first. He was pretty calm and easy, and then I had number 2, and that taught me that it wasn't about me, it was the temperament of my baby and who they were. So yeah, I'm not hard and fast on that. And have I used a pacifier with a baby under the age of 2 weeks? Absolutely. These babies, so I'm a big teacher of how to calm and settle. So one of the tools Dr. Sawyer mentioned swaddling and motion and swinging and side lie and reducing the moral reflex and using pacifier. So all of those things that we can do to help babies be calm also feeds into what you talked about earlier is depression. If you know how to settle your baby, you can calm your baby, a happier family, everything's going to go better. So I'm not that strict. At the same time, I talk about the things we talked about, which are, think about this, don't put it in when you don't need it, and be minimal. So I hope I answered that. And also that brings me to introduction of bottles. The sooner we do a bottle, the less chance breastfeeding lasts. So we try, but if you don't do it, then they won't take it. And now we have 10 mothers a week calling to say, how do I get my baby to take a bottle? I got to go back to work. And so we say by 4 weeks, and we talk about which type of bottle and the nipples and the slow flow and all of those things to support, and not using it too much. We have so many mothers that don't want to get up in the night, so they're bottle feeding, they're not pumping or nursing, and the milk goes away. Or the baby gets so many bottles, they don't want the breast because it's a very different system. And so we try to find that balance and try to encourage parents once they introduce it to keep it coming often enough so the baby is used to it 3-4 times a week or as much as once a day, but more than that. But I always say, look, it's a real world and there's going to be a day when, and you have to go to the doctor or you have an interview and you have to use more than one bottle, but don't try to do it every day that way. See what you can do. And just being completely supportive. And because the support groups are they're just teaching each other. It's just fantastic.
Corky, thank you.
I just want to say one other thing about the pacifier introduction. And
Yes.
Corky, you probably see this as well, but I do see parents who will say, oh, I have this baby and they're fussy and they won't take the pacifier, nothing works. And they're trying to give it and introduce it when the baby's sort of out of sorts and dysregulated and screaming and crying. And as with anything, introducing it during a period of calm and when you don't need it and you're not desperate and they're not desperate and everyone's not anxiety ridden is the best. And so doing the shushing and the swaying and the swaddle and introducing the pacifier at the same time is often going to be, you'll have better luck with it.
So true. It's like putting something in their mouth when they're already crying, just really makes them cry harder and be miserable. So yeah.
Those are great points. And Dr. Abrams, did you want to add anything regarding the sippy cup versus straw cup question?
Like Corky said, yeah, the straw cups typically are better, and that's what we introduced my daughter right away. And, when they're able to start having water, I, introduce the straw cups with the water, and hopefully that makes the transition off the bottle a little bit easier as well.
Excellent. Thank you all so much for answering those audience questions. And I wished we had time for one more question, but I think we're butting right up on the end. I do ask any of our facilitators or panelists this afternoon, if there are resources that you mentioned that you'd like to share with our audience, please feel free to drop those in our chat box for everyone so that they can access those. But this has been a fantastic discussion. Thanks to each of you, Corky, Dr. Abrams, and Dr. Green, for your time today and really just sharing your knowledge and the information and tips that you've brought to us that will really help mom, baby, and dad and the overall family all together. These tips for healthy moms, strong babies help the overall family. So we are truly grateful to each of you for taking time out of your busy day to join us this afternoon. We also want to thank our sponsor for today's discussion, Smile Generation. We are truly grateful for their investment in the health of moms and babies and their support of today's It Starts With Mom webinar. Thanks again to all of our viewers live and those during the recording. We hope you've gained information, tools, and resources that you can use in your personal life, but also within your community. Remember, March of Dimes is a reliable resource and support system for moms, babies, and families. Thanks again to all of you for joining us today, and we hope you have a great rest of your day. Thank you.
Thank you.
Thank you.